there again, if you treat the patient, ALT normalizes, histology improves, but YMDD resistance is very high. Again, Lamivudine, the long term, if you look at the long-term results of 4 years, even there the ALT can break up, still go up a little bit, and as you can see, after stopping the treatment, even it is worse. So generally we would treat the patient's seroconversion keeps on increasing when you increase the duration of the therapy. The E negativity just keeps on, and around people who have lower ALTs, they are less likely to clear the virus than people who have high ALT. Again, highlighting my point, it's good to have a high ALT in liver disease, because if you have a high ALT, you can see the E conversion rate on Lamivudine is around 70% after 4 years of treatment. Okay, fine. I'll just try to rush up because we have to all say our namaz. Duration of treatment, again we say 4 years, but the more you treat it, the better the outcome. I will not go in detail. Again, the mutations, unfortunately, YMDD mutation is not time dependent. The more you treat it, the more the mutations. That is the problem with the longer you treat, better for the E conversion, better for the ALT normalization, but worse for the YMDD mutation. Reactivation can occur, again I won't go in detail for the shortage of time, but post-treatment reactivation after 2 years, stopping of the treatment, half of the patients might relapse. The advantage is it's given orally, very well tolerated, few side effects, but the problem is YMDD mutation and high relapse rate is there, and that is very, very important. Interferon alpha, as I already showed you, I won't go in detail. Again, activation of the killer cells and direct inhibition of the protein synthesis at the DNA level. It acts as antiviral as well as immune modulatory. Again, interferon alpha, if you look at the results of many studies, these are 4 studies as you can see, untreated controls and INF alpha, thrice a weekly regimen. Again, the prednisolone could be withdrawn in about 36% of the patients, and the response rate is quite good as far as you can see, around 50% with this. Again, if you look at the long-term results, the control and the treated patient who develop hepatitis E antigen clearance is much higher when you treat the patient P, becoming very significantly for 96 weeks, thrice a week injection. Okay. Again, this is the meta-analysis of about 12 studies where loss of surface antigen occurred in about 11%, untreated it occurred only in 2%, liver decompensation less common, hepatocellular carcinoma about half as common if you remain it untreated, liver-related death about half as compared to no treatment with interferon. E antigenicity negative patients, again they respond very well. I won't go in detail. Again, interferon alpha therapy for hepatitis B infection. The advantage is good end treatment result, good sustained response rate, more than 90%, defined treatment duration of 4 to 6 months, because we know treating them for longer doesn't really help. Positive impact on disease outcome like hepatocellular carcinoma and liver preservation, and no viral resistance, YMDD resistance doesn't occur here. Disadvantages, it's difficult to tolerate every alternate days, fever, depression, thyroid abnormalities, so many problems with this, hair loss and neutropenia, thrombocytopenia, and all these can occur. This is comparison between the two, and as I showed you, the today advantage is to interferon. Future therapies, the Adenovirus, Attenacavir, they are being tried again as nucleoside analogs, and this is the this phase 2 study of E conversion. Again, a wonderful drug, not approved by FDA as yet, 10 milligrams OD. The response rate is very good and no YMDD mutation with this drug. So in the beginning, I think in the future we will be looking at this drug very carefully, Idiofer, which is already being used for HIV/AIDS patients. Okay, right now it is being used in patients who are HIV and hepatitis B virus coexisting, and FDA has just approved it, and people who have had a liver transplant done to suppress their viral loads so the transplanted liver doesn't get it. Idiofer, again, the only problem is a lack of sustained response in hepatitis B positive patients. Advantage is, again, oral administration, few side effects, efficacy in hepatitis B viral Lamivudine resistant patient. It is very effective, as I showed you quickly in a slide, that even patients who are resistant to Lamivudine, it can be used. Modest end treatment response. The problem is limited evidence, as we do not have many studies. Dose adjustments in renal insufficiency because it's kidney excreted drug. Post-treatment ALT flares, and no data as yet available. Attenucover, again, this is not FDA approved as yet, just finishing phase 2 trials. Quite effective. Again, PCR becoming negative in about after 6 months in about quarter of the patients. Advantage, again, oral, good response, but again we do not have data as yet. Pegasus seems to be of modest efficacy, which is once a week pegylated interferon, where you add peg of glycation to the ordinary interferon so that you prolong the serum level and the blood level of the same interferon. Generally, PEG interferon alpha 2A 40 kilodalton in hepatitis B is used. Phase 2, 3 and phase now 4 studies are available, post-marketing studies are available in positive patients, E antigen positive patients, E antigen negative patients, and it's the first pegylated interferon to have been extensively studied. This phase 2 trial, again, different doses of pegylated interferon, 270 microgram to 90 microgram, and compared to conventional interferon of 24 weeks follow-up. So this was compared. E antigen positive chronic patients were included, patients who had high ALT, who had positive Amplicor PCR, and liver biopsy, they had less cirrhosis, less than 20%. They had compensated liver disease. The TLC count was above 1.5 and platelet above 90. There were Asians, large Asian group in this study, okay, age matched, sex matched individuals in all the groups. The definition of response was end of E antigen loss, anti-hepatitis B E positive on treatment, quantitative hepatitis B E antigen coming down, and PCR becoming negative, and also E antigen loss, and it was determined by, again, Roche Amplicor system, and E antigen negativity was studied by Abbott system. Here are the results. You can see conventional interferons, still hepatitis B E antigen positive in around 25 to 30%, while in any dose that you used, so it doesn't matter what dose you use, so low dose is better, okay, once a week, 40 kilodalton usually would do the trick, okay, and normalize your E antigen. E antigen loss, as I said, even at a low dose was quite comparable to high dose, but better than conventional interferon. Sustained hepatitis B E antigen conversion on follow-up, again the low dose is as good as high dose, but better than conventional interferon. On treatment, PCR reduction, very, very important. Again, you can see the best results were with the low dose PEG interferon as compared to other doses or as compared to conventional interferon. Combined treatment response, both E antigen negativity as well as hepatitis B viral load on PCR negativity, again on 90 micrograms, around 27% response as compared to high dose, and overall if you compare all the doses, the response was 24%. So difficult to treat patient, what do you do? Difficult genotype, that is C genotype, which is less responsive. Again, you have to use a combination, again, effect of, this is Pegasus used alone in difficult to treat. Again, response rate initially not that good, but better than conventional interferon. And as you can see, if the viral load was moderate or very high, the higher the viral load, the better the response. The lower the virus rate, the lower the virus log, the better the response rate. But in very high viral load, still the response rate was 20%. Again, ALT and hepatitis E loss better in PEG interferon. Again, if people with low ALT and hepatitis PCR positive, again the response rate better than the conventional. Effect of genotyping, again B and C. B of course responds much better than C, but C still better response, much better response than conventional interferon, because C typically does not respond to interferons, but with Pegasus it does. Combined response.
Sir, do you think you are going into such sort of details which are not needed by
I am just rushing through, we can just discuss it. Yeah, okay, fine. I thought, different genotypes maybe, if you are fine, no problem. Anyhow, as I was saying that here again you can see combined response in different genotypes still better than. So safety at the end, all patients in phase 2, they tolerated Pegasus quite good. Classic interferon events observed in similar frequency against all interferon doses, but of course the lower the better. Neutrophil and platelet count reduced during treatment but returned after stop of treatment. It is a reversible neutropenia and reversible thrombocytopenia. This is the neutrophil count. As you can see, it did go down, but not touching the dangerous levels even at very high dose, and coming up after stopping the therapy. Again, the platelet count, very similar story. At the end, the conclusion is that the Pegasus once weekly shows significant promise in the treatment of patients with hepatitis E antigen positive chronic hepatitis B. Pegasus 180 microgram demonstrated greater efficacy and reduction of hepatitis B viral DNA load to less than 500,000 copies per ml, reduction in hepatitis E antigen and in the combined response of E antigen negativity and PCR is there, and of course it was well tolerated. It is associated with a better efficacy rate than conventional interferon. Low pre-treatment ALT patients responded better with Pegasus, and high pre-treatment HB DNA load, viral load, if it was higher as compared to conventional, definitely it had edge in these two groups. Results of quite a number of phase 3-4 trials are still being awaited. Thank you very much for your attention, and I do apologize for going in detail.